going to cut the rambutan, take the seed out, look at the gene. So by understanding that, we can plan your treatment option for your best results for that individual person.
When you found a lump, don't be scared, all right? Because 80% of all lumps are not cancerous.
So you're telling me that if there's a lump, we don't actually have to go for surgery to remove the lump?
In this second episode of the Breast Cancer 101 series, learn how breast cancer is diagnosed. Check out the previous episodes on Talk Health Asia's YouTube channel, subscribe, and stay tuned for the upcoming episodes.
We've been talking about breast screening. Let's talk about, so if you've self-examined, you think there's a bit of a lump, you go for breast screening, you found something. What's the next step? How do we test whether that lump is actually cancer or not? So what do we do at this point when we found a lump? But how do we know if it's cancer, Dr. Teoh?
When you found a lump, don't be scared, all right? Because 80% of all lumps are not cancerous. They are not cancerous. 80% are usually benign. Benign means it's not cancerous lump. Only 20% of the breast lumps are cancerous, all right? 20%. So the rest of the lumps are like fibroadenoma. These are benign lumps like fibroadenoma. You will hear a lot, breast cysts, okay, or sometimes infection, abscess, or fibrocystic changes, all right? So what must you do when you find a lump? So when it comes to breast lump investigation, we call it triple assessment, okay? There are three things that you must remember. One is go and see your doctor. They will do a breast examination for you. And the second one will be do your mammogram. They will arrange for a mammogram and an ultrasound. And if the lump is suspected to be suspicious, or if they want to be sure what it is, then they will recommend a biopsy. All right. So see the doctor, get a mammogram and an ultrasound, and a biopsy. Okay, because we need to test. By looking at it, we cannot be 100% sure.
Are there different types of biopsies that we're looking at?
It's actually when we take a sample of the tissue. And how do we do that? Right, those days we used the surgeons, when we didn't have all this newer technology, ultrasound method, right, small little needles to extract the tissue, we do a surgery, all right? But nowadays we do not do a surgery. We take a core needle biopsy. There are two methods. One is using a fine needle, and another one is a core needle biopsy, but generally get a needle biopsy, all right? So a common one is an ultrasound guided core biopsy, whereby we will insert the needle into the lump using an ultrasound to look at the lump, and we will extract the tissue. It's a very fast procedure, very safe procedure, and it does not cause the cancer to spread. All right. So it'll come out like little charging tissues like that. All right. And usually I tell my patient 95% of the time there's no pain. All right. Yes, 100% you'll be very scared. All right. And it's a quick procedure, about 2 to 3 minutes or 5 minutes.
Okay.
Yeah.
I see.
All right.
So you're telling me that if there's a lump, we don't actually have to go for surgery to remove the lump?
No, you don't have to go for surgery to remove the lump. First, we will take the sample, confirm what it is. All right. If it's a benign lump and you want it to be removed, then yes, then you can go for the next stage to remove the lump using a surgery. But if it's a cancerous lump, then we need to do the biopsy, because after the biopsy, we have several different treatments for you, which is very important for your survival.
Now, we've been talking a lot to Dr. Teoh, right? And let's hear a bit from Dr. Mas. So we talked about biopsies, found out that, the lump is actually cancerous. What is the next step at this point?
The next step would be staging. So staging, if you look at the word stage, it means a point, a period, or maybe a step in a process, a development of some sort. So such as, cancer. So cancer staging is a process to investigate basically the volume and the spread of the breast cancer. So how much is the cancer? How large is the tumor? What is the extent? Where has it spread to? So it is important because it helps us doctors to quantify how serious the cancer is and what are the chances of survival for the patient. So what we call prognosis. So by understanding that, we can plan your treatment option for your best results for that individual person. So if you look at this picture, right, the staging, I didn't put stage 0, but stage 0 is basically ductal carcinoma in situ, or DCIS. You may have heard of that. So this is the cancer where, it began there. So what I usually say is the cancer is like a baby that is unborn. So the baby is, the cancer is there already. It's just like a baby. It's alive, right? Just that it hasn't been born. So the cancer has not come out yet, but it's there. So that is DCIS. But then you can see that stage 1 is in the first picture. The cancer is small, has not spread anywhere else yet. Stage 2, if the cancer has grown a bit bigger, or it has spread but minimally to just a few of the armpit lymph nodes. Stage 3 means it's more. The cancer is bigger, it has spread to a few lymph nodes and more regions in the area of the breast. And stage 4 is, as you know, the cancer has actually spread to other parts in our body, at least 1 or maybe 2 organs like that. So these are what we call secondary or metastatic breast cancer. So these are basically what we have to do so that we can, prognosticate as well as plan treatment for you, what we call staging. So how do we do that?
Yeah.
Of course, by clinical examination. And then we do what we consider as imaging scans. So imaging scans, there are like various ways on how we do our imaging to see what is the cancer extent. So we can do, something simple like chest X-ray or ultrasound of the abdomen. As you can see there, these are usually for very early stage cancers. You don't need, sophisticated imaging like CT scan or PET scan. So if you have DCIS, don't ask for PET scan. So if you have, really small tumors, elderly patient, good type of cancer, hormone receptor positive, so you do not require very sophisticated imaging like CT scan, MRI, bone scan, or PET scans. So these are usually for patients who have more advanced cancers. They have or more clinically aggressive type of breast cancers like triple negative or HER2 positive. So they have the likelihood of detecting something elsewhere is actually higher in these patients. So we would do those imaging scans for them to stage the cancer. Other than that, I guess talk to your doctor and know what is that size that fits you, because there's no one size fits all kind of staging. Not everybody needs PET scan, not everybody needs bone scan. So your team will advise you on which are the staging modality that is required for your type and potential stage of cancer. Okay. Another thing, Pauline, that sometimes patients confuse with stage and grade. So sometimes they say, oh, doctor, but my surgeon told me I'm stage 3, but it's actually grade 3. So grade.
What's the difference?
So grade is actually depending on how your cancer cells looks like on the microscope. So stage is like, what?
Where it's spread.
Where, kan? What, where. But grade is your individual cancer, how it looks like on the microscope. So that is in the lab. So in general, lower grade 1 indicates a slow growing cancer. So grade 1 is a good grade. So grade 3 means that it's now a faster growing one that may grow or spread or behaving more aggressively. So grade 3 is not good. So grade 3 is often an indication for us to offer chemotherapy for patients. So that's just an example. So that's grade. Okay, so that's different from stage. Of course, stage and grade combined will help us in deciding patient's treatment or patient's
It'll
prognosis.
give you a more holistic picture of what the cancer is
other
like,
than
isn't it?
stage. Yeah.
I see. And if you've staged the cancer, what's the next step? Because I hear that, is there only one type of breast cancer?
Of course not. So if you could look at this slide now, why are there 3 different breast cancer subtypes? That is because cancer is basically a process where your normal cell has undergo a sequence of mutation. It evolves to become a cancer stem cell, So a few mutations has occurred to the normal cell, and this happened months, maybe years, maybe 2 to 5 years of this process happening to your normal breast cell. And then this develop into these breast cancer stem cells. So these breast cancer stem cells is a what we call pluripotent cell, It can become just anything. So it can become a hormone receptor positive type of cancer, it can become a HER2 positive type of cancer, or it can become a triple negative breast type of cancer. Sometimes over time, if let's say the cancer is not diagnosed, they can change some more. So for example, they can become in hormone receptor positive type of cancer first, and then after, like, if the cancer is not treated, then it just sort of evolve into a different one. Or it can you can have a mix, like in one tumor that is about 3 centimeter, you have a proportion that is triple negative and you have a proportion that is hormone positive. So if you look at basically how we generally divide the cancer, right? So we divide it into hormone receptor positive type of cancer. That means the cancer is ER, PR positive, and the
Okay.
HER2 is negative. Or we can
Okay.
have, that is basically the majority of our patients. So about 50 to
Right.
60% of our patients are in this group. The
Hormone
second
positive.
group, the second group is the HER2 positive, human epidermal receptor 2 positive. So this cancer is involving about 1 out of 4 patients with breast cancer will have this type of cancer. So this cancer means that the HER2 molecule, which is on the cell of the surface of the cell, is a bit more than usual in number. So because it's more than usual, then it causes this aggressiveness in its behavior. Okay. The third group is the triple negative subtype, which means that the cancer is not hormone positive, neither it is HER2 positive. So is the cancer of unknown. I mean, the cancer is just so different from the original normal breast cells. So then it becomes triple negative. So this is supposed to be the most aggressive of all the breast cancer types. And luckily, it only affects about 15, maybe the most is 20% of our breast cancer population. So these are generally the 3 group of breast cancer types that we have. And it's important for us to know this because this is like the IC, the identification, identity of each person with breast cancer. So whenever you see any oncologist with your breast cancer diagnosis, we will say, what is your ER/PR and HER2? That's like your identity, your passport number kind of. Okay, but there's another type that is sometimes patients ask me, what is triple positive breast cancer? So there's triple negative breast cancer. What is triple positive breast cancer? So if you look at the middle one, HER2 positive, right? Half of them are HER2 positive, yet the ER/PR is negative. Half of them are HER2 positive and also hormone receptor positive. Okay, but because the HER2 positive is like the more dominant one in controlling the cancer, then we lump the 2 triple positive and the hormone receptor positive, hormone receptor negative, HER2 positive in one group. They're treated like HER2 positive.
Wow, that's a lot to take in. I mean, with all the different terminology. When we talk about hormone positive and HER2 positive and triple negative, when we're trying to classify this, what are some of the tests that we actually have to do? Do we see the breast oncologist? Do we see the breast surgeon to do these tests?
Okay, so often when breast surgeons do the biopsy of the breast tumor, okay, and that's why Dr. Mei Shi highlighted just now, the core needle biopsy is very important rather than an FNA, okay, to get enough tissue for us to confirm it is malignant. Second thing is to do that test, what we call immunohistochemistry test, IHC, to determine the ER, PR, and HER2, and maybe the grade, as well as another one called Ki-67 or MIB1. So that's almost near like the grade lah. It tells us about the proliferating capacity of that breast cancer. So these 5 information that an oncologist require, apart from the staging. So we need to know the stage, we need to know the cancer, and we need to know the ER, PR, and HER2 in order for us to tailor how are we going to manage this patient now. How do we sequence the treatment? Is it chemotherapy first, chemotherapy plus anti-HER2 first, or is it followed by surgery, or is it upfront surgery followed by So the sequence of the therapy depends on this information. So that's why it's very important that we do it right from the very beginning.
I see. We have a question from FW, and FW is asking, what is the meaning of HER2 equivocal? Okay,
HER2 equivocal means that, okay, so if you imagine that your breast cell is like a rambutan fruit, just imagine a cell looks like a rambutan fruit. So the rambutan hair is HER2. Okay, rambutan hair is HER2. So this HER2, the rambutan hair is HER2. The number of HER2 on the surface of the rambutan kulit, right, is determined by what is the gene copy number of the nucleus, which is in the rambutan biji. I'm not sure how the seed lah. Okay.
The ulas.
So
Yeah.
the seed of the rambutan, the
okay.
biji, at the biji there, there's the genetic code that determines
Okay.
how many rambutan hair is out there. So how many
Okay.
HER2 is out there. So now, if let's say we try to determine, okay, we want to test the cell to see whether the rambutan hair is thick or thin. Okay.
Right.
So if it's thin, it's normal. So we say, okay, this is HER2 negative. Okay.
Okay.
If it's very thick, okay, this is HER2 positive when we do the IHC. But if
Right.
it's in between, like neither thick nor thin, it looks like
Okay.
sedang-sedang. We're not sure yet. Now we say, oh, it's equivocal. So we're going to cut the rambutan, take the seed out, look at the gene inside the seed, which is what the test that we do, which is called FISH.
Right.
We do a FISH test to
Okay.
look at what is the genetic copy number that determines the HER2 molecule number out there. So if let's say now the genes for the cell is actually extra, that means the one that we're seeing just now, like not sure, is it thick or thin, right? It's actually thick lah. So means it's
Okay.
positive. If let's say we look at the gene number is low, okay, it's
Yes.
low, then it's HER2 negative. That means
I
what we're
see.
seeing is just a random,
It's a
subjective.
random anomaly, right?
Yeah.
Gosh, I
Something
don't
like
think I
that.
can look at a rambutan the same ever again after your analogy. With all of that, is there a role for cancer markers, tumor markers in all of this diagnosis?
Okay, for early breast cancer, I would say no, because early breast cancer means that the cancers are small. Okay, the cancers are small. They are not emitting any markers, means any proteins. They're not basically emitting any proteins that goes into the circulation where you can pick it up when you do blood tests. They don't. Okay, but sometimes when you have metastatic breast cancer, means that you have a lot of cancer volumes in your body, and there is cellular damage, mean the cells get damaged, and then they shed some proteins like CA or CA125 or CA99 into the circulation, but that's not common. So
I
for
see.
detection of cancer, where cancer are really small, really early, then we do not do tumor marker for detection. We don't.
Okay. Now I see many questions floating on to the next test I want to talk about, BRCA testing.
Okay.
Dr. Mastura, can you tell us a little bit more about BRCA testing and I mean, with breast cancer that's genetically linked, questions are coming through whether BRCA1 family members should be doing preventative surgery and things like that. Can you explain a little bit more about what BRCA is?
Okay, so BRCA basically stands for breast cancer and ovarian cancer related genes. That means that genes are basically our code. Like you have a gene for black hair, you have a gene for blue eye. So these are like what you were born with. You inherited that gene from your parents, okay, either one of your parents. So if a person inherited a defective BRCA gene, so BRCA gene is a gene that is responsible for cell repair. Means that in our body, we are constantly having cellular damage. That means the cells get damaged. Cells try to divide, but there's some error in the division in the daughter cells. So the body has to repair it. So the gene that is responsible to repair, one of it is the BRCA gene. So if you are born with a defective BRCA gene, you will still be okay for a good number of years because you inherit a good gene from one parent. So let's say I will use myself as an example. Okay. So let's say now I was born, I inherited a defective BRCA gene from my father. Okay. My father never had cancer because he died. Let's say he died at 50 years old. He didn't had the opportunity to develop cancer, but he actually was a carrier of a BRCA gene. Let's say. So now I inherited the gene from my dad. Okay. So now every cell in my body, for the BRCA gene, one is a defective one, the other pair is from my mother, which is a normal one. Okay, normal one. So all my life until I reach 40 years old, my mother's normal gene has been doing the repair process.
You.
Yeah, it's helping me doing all the work.
Okay.
Then at age 40, the cell that is in my breast or the cell that is in my ovary, the normal gene from my mother, right? Now become defective. Because of other causes because of, let's say, environmental causes, smoking, whatever. So the cancer starts to happen. Okay, so the cancer starts to
Right.
happen in the breast or in the ovary. So that means I get breast cancer or ovarian cancer at age 40, carrying the defective BRCA gene. So
I
that means
see.
that if I can get a cancer in my right breast, I have the same gene on my left breast. So the same process can happen in my breast, can happen in my ovary, in my pancreas, in my colon. That means because I carry it in all my cells. You can find the BRCA gene in my hair, in my blood, in my skin. You see, so I can get cancer everywhere. It's just that the most common cancer that happen in a carrier like me is breast, ovary, pancreas, colon. So there are common cancers that you normally get if you carry a gene such as that. So now, if I have already gotten married and I have gotten the breast cancer, I know I test myself. I take my blood, I send for the germline BRCA testing, confirmed to be carrying BRCA1 or BRCA2, right? So I have 3 children. So when my children reaches age 21, I would advise them to basically do the test themselves, because 50% of the time, each offspring may carry the gene that they carry from me when I have my children. So when my children reaches 21, they get the counseling, then they get the testing. So if let's say 1 out of 3 is a carrier, then this child of mine will have belum dapat cancer lagi, not yet, but will go on to have further counseling in order to know how can we reduce the risk of this child from getting cancer.
Brings us to a question by Melanie Hill, right? If it's BRCA positive, do we need to remove both breasts, even if there's no cancer on the other side of the breast?
You're talking about a carrier or somebody who already have cancer here? Because it's different.
Right, okay.
So if you're
right.
talking about a carrier, means somebody that doesn't have cancer yet, but carries the gene, like Angelina Jolie, right?
Yes.
Yeah.
So that's
So
preventative, right?
Correct. So she does a preventative surgery, means that she doesn't have breast cancer yet, but she doesn't want to get the breast cancer. So she removed her breast in order for her to reduce the risk. But the reduction is not 100%, but reduce the risk by removing her breast. And later she removed her ovaries in order for her not to get ovarian cancer. But for someone who like I gave my example just now, I already have breast cancer and I'm a carrier, right? So at the point that I'm diagnosed with breast cancer, if I know already that I have the BRCA mutation, I haven't done any surgery for my affected breast, right? I can decide at that time point to remove my other breast if that is what I want. But that's not for everyone, you see. So a patient may not want to do that yet, because not everybody can just, accept that rather freely. So we can give time for the patient. If let's say the patient is a BRCA carrier and already diagnosed with right breast cancer, right? So the right breast, we would say, okay, we would prefer that the patient remove the entire breast rather than doing a white local excision, because leaving the diseased breast, half the diseased breast, you still have a risk of getting another cancer in the future. But sometimes patient needs time to think. So we will give them time. We will treat the cancer first. The being the carrier is secondary.
Right. I'll just take one last question on BRCA. Does every breast cancer patient, is the BRCA test recommended for every breast cancer patient?
Okay, at the moment, the reason why we are increasing our advice for patients to do BRCA testing is because there are available treatment for these patients that develop breast cancer that is associated with having BRCA gene. So because of that, we are increasing, last time we used to say, okay, triple negative breast cancer, those people with family history only actually does the BRCA testing. Nowadays, we say, okay, anybody with any type of cancer, the 3 types of cancer that I mentioned, any type of cancer and diagnosed below 50, no family history whatsoever, we recommend that they do the BRCA testing, or maybe they do not just BRCA, but maybe they can also do PALB2, they can also do check, ATM, there are the P10, there are other genes as well. Okay, so below 50. But let's say you are a triple negative breast cancer patient and your age is 60. So triple negative breast cancer compared to the other 2 subtypes are more aggressive, but also more likely to be associated with BRCA. So the
I see.
percentage of BRCA mutation is highest in triple negative breast cancer. It's highest in younger age population. So there is like, if let's say you kumpulkan a few young breast cancer patients with triple negative breast cancer, their likelihood, the likelihood of you getting BRCA in them is high. It's probably 15 to 20%. Okay, but
Right.
if you take the whole breast cancer population, it's about 5 to 8%.
And this is another term that I've often heard, sentinel node biopsy. Dr. Teoh, what is sentinel node biopsy? It's very foreign to me.
Oh, sentinel node biopsy is a biopsy is basically a sampling of the tissue as well. But sentinel node, we are talking about the axillary lymph nodes. All right, sampling the axillary lymph nodes, and this is we do it for breast cancer. Once the breast cancer has been diagnosed, and then if you're going for the breast cancer surgery, then we will do the sentinel node, whereby we will extract the first few nodes that the cancer drains into before it goes to a different stage. All right, so to do the sentinel lymph node biopsy, right, there are two ways of extracting the tissue, detecting it. The one is using the blue dye, okay, the other one is a radionuclear.
I have a question for you, Dr. Mastura, because you do a core biopsy, right? And then the patient, the woman hears that she has cancer. One of the questions that was asked was, do you have any advice, Dr. Mastura, for a woman receiving news that she has cancer? How best to cope with the situation at that point?
Okay, first thing first is the woman, before they even come to this revelation consultation, right? It's advised or recommended that they come with accompanied by someone. So at least they're not alone hearing the message. Okay.
I see.
Second is I would prefer that the patient listens to what we say rather than convoluting their mind with that, the word cancer in large, like cancer, So we don't want that, because just listen to the doctor, because the doctor often will look at the diagnosis and try to find a solution for you. Okay, so there are some processes that has to be done after a diagnosis is made in order for us to understand and try to formulate what is the best treatment option for the patient. So if the patient is not listening, it's difficult for that conversation to flow and for the patient to ask the correct questions. So when you listen and you ask the correct questions, then you will understand it better, and your emotion will become calmer, better. The person who accompanies you helps in also listening and taking in points so that this can be explained to the patient in a layman term better than probably the doctor.
So if I were to summarize what Dr. Mastura is saying, she's saying go and see the doctor together with somebody.
Correct.
Right, Dr. Mastura?
Yeah.
Together.
Yeah. Yes, together. Yes.
So if the size of the tumor is smaller, then we can offer you a breast conserving surgery. We may need to remove your breast because of the better cancer clearance, but at the same time, we can rebuild your breast for you.
It takes time for a woman to be confident about having a sex life again with their partner after they have had the treatment done for them. But it is very doable.
Saying is, when you do a lumpectomy, you need to do radiotherapy, and otherwise you have to do a mastectomy. Is that right?
Subscribe to Talk Health Asia's YouTube channel for more health chats episodes, or find easy to understand health videos on talkhealthasia.com.